Hello, hello, and welcome to this lecture on tremor and movement disorders in general. My name is Viraj Barambi. I'm one of the registrars at the Wollaston Centre in Liverpool in the UK, and hopefully I'm going to cover this topic in about 40 to 45 minutes. I don't have a first slide with learning points on it. The learning point slide is kind of actually at the end of the lecture, so if you want to fast forward and see that now, please do. But essentially, I'm going to be talking about movement disorders, and when we talk about movement disorders or think about them, really, the simplest possible way, clinically, we divide these into too little movement or too much movement. And first of all, I'm going to talk about disorders that have too little, and then we'll move on to too much. Okay, so again, in the most basic fashion, too little movement is called either bradykinesia, just like we call a slow heartbeat bradycardia, or akinesia, which is kind of a worsened form of bradykinesia where you can't move at all. So, too little movement is bradykinesia, too much movement is hyperkinesia. Very good. Or dyskinesia, and we'll get to what the differences are later on down the line. And when we talk about these in terms of conditions, when we talk about bradykinesia, really what we're talking about is Parkinson's disease and Parkinsonism. And I will try and explain what the difference is between those two in a moment. And then when we talk about too much movement or hyperkinetic movement disorders, we're looking at tremor, dystonia, chorea, myoclonus, and tic disorders. And I'll explain each of those in turn. And there's going to be lots of videos in this presentation, so hopefully that should make things a little bit more clear rather than me just explaining them. Good, so let's go to the one that you're probably more aware of first, so too little movement, bradykinesia, or Parkinson's disease or Parkinsonism. So, what do we mean by Parkinson's disease? Well, we talk about this conglomerate of symptoms, this syndrome of an asymmetric onset of slowing down of movement, bradykinesia, rigidity, where movement through all ranges is stiffer. We have a resting tremor, so a tremor that's predominantly there distally in the hand at rest, and postural instability, so they tend to fall over quite a lot more. They also have these other features, such as soft voice, or what we call hypophonia. They also have a sort of a blank or an expressionless face, which we call hypomimia, and small handwriting, which is termed micrographia. So, and this is the classic sort of a diagram of what someone with Parkinsonism looks like. Their gait is also quite different. They have shuffling gait with short steps, what we call a festinating gait. They have reduced arm swing, which is one of the very earliest signs in Parkinson's disease, asymmetric loss of arm swing. And sometimes they can have a rigidity and trembling of the head and this forward tilt or this sort of stooping posture. Very good, so that's kind of just telling you more of that. And here we have a video of, you can see this asymmetrical tremor on the right, stooped posture, these short steps where the foot isn't quite clearing the other foot there. Okay, and I have another video just here where you can see it's quite a blank face, not a lot of expression, and the voice is quite soft. You can see this tremor on the right side, which is there at rest.
Okay. You put your arms out like this.
And this is a way to clinically demonstrate bradykinesia.
Okay.
Well, first of all, you can see that obviously the tremor almost goes away when you have the arm in posture. So you can see the movements from
And the S.
nose to finger are quite slowed. Very good. Okay. So, and here I think we're demonstrating a rigidity through all ranges of movement. So a sort of cogwheeling. Maybe you can. It's difficult to see. It's more easy to feel cogwheeling. Very good. Okay. So, and this video is to show the bradykinesia. So you can see the opening and the closing of the hand is very slow, and as the more he does it, the amplitude decreases. So there is a decrement in amplitude. So both those features are quite important. Both the bradykinesis, so slowness of movement, but also a decrease in amplitude the more the movement is intense. Okay, so I think that's all the main features of Parkinson's disease. And to move on to, again, we're sticking to idiopathic Parkinson's disease here, not Parkinsonism. I'll talk about those different disorders momentarily. But Parkinson's disease, the cause is unknown. There's loss of dopamine secreting neurons in the substantia nigra of the midbrain. So we know it's a neurodegenerative disease, but what kicks it off or what causes it is still not quite clear. So I've spent some time talking about all the what we call the motor symptoms of Parkinson's disease. So all the things to do with movement or lack of movement, slowness of movement, and tremor and those kinds of things. But there are many other aspects of Parkinson's disease which are non-motor. So mood disorders, cognitive changes, hallucinations and delusions. Orthostatic hypotension, so this phenomenon of low blood pressure on standing and sometimes leading to syncopal faints, and constipation, which is very common indeed, as well as fatigue and sleep disorders, specifically REM sleep behaviour disorders. So in terms of how it is that we as clinicians come to the diagnosis of Parkinson's disease, well, it's the conglomerate of symptoms that I've explained to you so far. They need to have the motor symptoms as well as some of the non-motor symptoms, but really there is no diagnostic test. There are these scans called DAT scans, but really they're not particularly useful, and we need to make sure that there's nothing else that can be causing these sorts of disorders. Often the drugs that we use for schizophrenia, so some of the typical antipsychotics, can cause a Parkinsonian syndrome that can sometimes be wrongly diagnosed. So if you find someone with bradykinesia, cogwheeling, rigidity, tremor, all these things, make sure you check their drug chart and make sure they're not on any typical antipsychotics that might be causing this syndrome. The treatment of Parkinson's disease is a little bit complicated, but essentially the sort of gold standard drug we have for Parkinson's disease is levodopa. It's a very effective drug in the early stages, but as the neurodegeneration progresses, patients can develop what we call motor fluctuations, and actually the levodopa can work too well and cause excessive movement, such as dyskinesias. There are other adjunct medications you can try in addition to levodopa. These include dopamine agonists, which are good drugs, but they have their own side effects as well, which we'll touch on shortly. Amantadine, which was originally created as an antiviral drug, but found to have good effects in Parkinson's syndromes as well. Monoamine oxidase B inhibitors, so these reduce the breakdown of dopamine and therefore increases bioavailability of sort of endogenously created dopamine. And the same goes for COMT inhibitors such as entacapone. They decrease the breakdown of dopamine, therefore making it more available. And this is a complex diagram, but worth getting your head around. So if you want to pause at this point before I move on to the next slide and just get your head around what it is that, where it is that all of these medications work and how they're supposed to help in Parkinson's disease. Motor complications. This is essentially when you know that the patient is progressing in their neurodegeneration. So as I explained earlier, because it's a neurodegenerative disease, no matter how much levodopa you give them, it won't stop that neurodegeneration. It will help them symptomatically, absolutely, but that will have a lifespan. And after some years of levodopa therapy, what the patient will start complaining of is either that the tablets aren't lasting long enough, so they're becoming very Parkinsonian, or that they're working too well and they're becoming hyperkinetic and they're getting dyskinesias. Later on down the line, the levodopa itself will cause hallucinations and confusion. So when you get to this stage, you need to think of some other options that don't cause such rapid sort of peaks and troughs of blood dopamine levels. Now, your three main options here are something called an apomorphine infusion, or jejunal levodopa infusions, or deep brain stimulation. So the picture here is actually an apomorphine infusion. It's a small subcutaneous needle connected to a pump which delivers apomorphine. So that drug has nothing to do with morphine at all. Apomorphine is a dopamine agonist, just like pramipexole or rotigotine or all those classes of drugs that we just talked about. And it basically means you get a constant infusion of dopamine agonist, which leads to more even relief of Parkinsonian syndromes. The other option is this. This is a duodopa infusion, so a jejunal levodopa. This is a PEG tube. So that tube goes directly into the patient's jejunum, and that pump there essentially gives them dopamine in a gel format into their jejunum. What that does is again give you a nice even dosing of dopamine so that you don't have the large peaks and troughs which cause the motor fluctuations and lead to on and off phenomenons and dyskinesias. And the last of the advanced treatments for Parkinson's disease at the moment is deep brain stimulation. So here you can see that the patient has two leads or electrodes planted in generally the subthalamic nucleus bilaterally of the basal ganglia, and those leads or electrodes are connected to a sort of pacemaker type device that's inserted in the chest wall. And essentially that pacemaker type device is the battery, and they overcharge the leads so that they electrically lesion the subthalamic nucleus, and in so doing they decrease the activity of the indirect pathway of the basal ganglia, and hopefully cause relief of symptoms. So I've talked about idiopathic Parkinson's disease, but there are lots of conditions in which a patient presents with the features of Parkinson's, so what we call Parkinsonism, right? So bradykinesia, rigidity, a tremor, the gait abnormalities, all of the symptoms, but it's not quite so asymmetrical. In fact, it will often be symmetrical. And when you try levodopa, it doesn't really seem to work. And when you have these situations, we call these situations Parkinson's plus syndromes. And generally, when we talk about those, we mean these 4 syndromes most commonly. There are many others, but these are 4 that matter, or the ones that you're more likely to come across. So all of these will present with some of the features of Parkinsonism, but they will have some additional features too, so that's why Parkinson's plus. So the first one to talk about is a progressive supranuclear palsy. This is again a neurodegenerative, all of them are neurodegenerative conditions, but this particular condition, PSP, is more characteristically associated with a vertical gaze palsy and early postural instability. So I said earlier that in Parkinson's disease they get postural instability. That tends to be a sort of later feature, years down the line after they've had these symptoms. But in progressive supranuclear palsy, their postural instability is one of the earlier features. It presents quite early on. And that comes with a vertical gaze palsy. And what I mean by that is that when you ask the patient to look up towards the ceiling, they find it more difficult to do so. But importantly, and more specifically, when you ask the patient to look down, they're unable to do that as well. So moving the eyes horizontally from left to right, no problem whatsoever. But up and down, the patient really struggles. So that's PSP. Another condition, again a neurodegenerative condition, is corticobasal degeneration. This again comes with all the signs of Parkinsonism that we've spoken about, but they also tend to get a unilateral sort of limb signs in an upper limb. So often they'll get myoclonus, which again I'll explain later on down the line, and they also get this alien limb phenomenon, which is when the patient feels like the arm is doing things without them meaning to. It's doing involuntary movements. And it's often also associated with the unilateral dystonia. Again, I'll explain what dystonia and myoclonus mean as well as apraxia later down the line in this lecture. The third condition to be aware of is dementia with Lewy bodies, and really the hallmark feature of dementia with Lewy bodies is cognitive decline and hallucinations. These are early features. So if you have a patient that comes with signs of Parkinsonism and either at presentation or within the first year of symptom onset, they develop memory problems, cognitive complaints, altered consciousness, hallucinations, any of those features really, you're probably thinking that this patient is more likely to have dementia with Lewy bodies rather than Parkinson's disease. And that's important to know because often giving patients with dementia with Lewy bodies an L-DOPA regime will make them significantly more confused. And the last of the Parkinson's plus syndromes to be aware of is multiple systems atrophy. So this is a condition in which, yes, they have Parkinsonism, but they also have quite prominent dysautonomia. So this includes orthostatic hypotension, so this is what I talked about earlier, where you feel lightheaded when you stand up and your blood pressure is very low, but also lots of other things like sphincter disturbance and cerebellar ataxias and stridor. Again, poor response to levodopa therapies in this particular condition. Good. Other causes of Parkinsonism include vascular Parkinsonism. So this is if you have multiple strokes across the basal ganglia, and because of multiple strokes you deplete your dopaminergic transmission and cause Parkinsonism that way. As I've already alluded to, drugs that block dopamine, and specifically the typical antipsychotics, but also the atypical antipsychotics, can cause Parkinsonism. And other causes include infection that can damage the basal ganglia, especially HIV. So that's a whistle-stop tour through too little movement or bradykinetic movement disorders. So let's talk a little bit about hyperkinetic movement disorders and tell you about what all these terms mean. So tremor. Tremor is a rhythmical, oscillatory movement of a body part, usually around an axis. And with tremor, you can really ask a lot of questions in order to try and work out exactly what's going on. These questions are: is the tremor there at rest, so when they're just sat there doing nothing? Is it there on posture, so when you ask them to put their hands up in the air in front of them? Or is it there on action, for example, when they're walking or when they're moving their hand from their nose to your finger? Is it coarse or fine? So is it a very small amplitude or is it a very high amplitude? Symmetrical or asymmetrical, is one hand affected or both hands or both feet? And where is the tremor? Does it affect the head? Does it affect the hands, feet, legs, jaws? And are there any associated features with the tremor? Is there any vocal disturbance? Is there speech or swallow disturbance? Is there any abnormal posturing? So the first of these, the rest, action, or posture, really differentiates between whether you think what's causing this is Parkinson's, whether you think it's some of these other conditions, or whether you think it's cerebellar. Now, I'm going to show you some videos to try and differentiate what these different conditions are, but let's go first to probably the most common tremor out there, which is benign essential tremor. Okay, so these are generally very regular, quite high amplitude movements that often respond to beta blockers. So this is a quick video of essential tremor. So you can see that at rest, no tremor is present. And then you can see it's quite fine. But perhaps you can appreciate that there's a bit of a tremor on posture. There we are, probably more pronounced there. You can see that rhythmic oscillatory movement. You see that, just slight tremor there. A bit of a subtle one, this one. And you can see as the patient approaches the finger, the tremor seems a bit worse. And this is common of essential tremor, where approaching makes things worse. And holding a cup can be one of the more difficult situations. This is what patients usually present with, that when they're drinking, they find it very difficult because they're spilling water and spilling drinks. Very good. Okay, so benign essential tremor, essentially it's postural, it's symmetric. There's often a familial component, so they'll say that their parents or their siblings also have it. And quite importantly, it can involve the head and the voice, but the limbs are the most prominent. So often you can bring it out by asking the patient to hold a note like ah, and sometimes you can hear the warbling of the voice, and also you can sometimes hear yes, yes, or a no, no head tremor. Often patients say that the tremor gets worse when they're stressed or anxious or with caffeine, and interestingly, it gets better with alcohol. As I said, it's a fast, high-frequency tremor, whereas Parkinson's is a slower, lower-frequency tremor, and it's very slowly progressive over many years, and generally that's why we call it benign. It doesn't mean that there's any neurodegenerative condition at play. It often responds to propranolol or primidone, but we try and avoid these medications as they can often cause sedation in patients. The other quite common tremor is a physiological tremor. So this is essentially a tremor that we all have. If you put your hand out right now, it may not be there, but you have 2 or 3 coffees, you'll probably get an enhanced physiological tremor. And sometimes it can be quite annoying to patients, but it doesn't usually require treatment. So to move on to one of those other terms I used, dystonia. What do we mean by dystonia? So dystonia is often a sort of patterned movement that is twisting or writhing around an axis. It's less regular than tremor. It's often asymmetric, unlike sort of essential tremor. And there's often an associated muscle hypertrophy. So, the most common type of dystonia that you'll probably come across is a cervical dystonia. This is a dystonia in which the neck or the head is pulled to one side, and you'll often see overactivity of a sternocleidomastoid muscle and very bulky sternocleidomastoid muscle with that muscle hypertrophy, with an elevated shoulder on the same side. Dystonias are unique in that they have something called sensory tricks or a geste antagoniste. This is when a patient can press or just touch actually a particular part of their face, and it allows them to stop the tremor and move their head back to one area. And this was obviously, it sounds like a very strange phenomenon, and for years and years, neurologists considered dystonia to be a functional or a psychogenic disorder, but there's now a great deal of evidence to show that it's quite organic. So it's characterised by sustained contractions of agonist and antagonist muscle groups with twisting movements and abnormal postures or repetitive movements. So, in general, how do we examine tremor? Well, first of all, you observe at rest. Then you put their hands in positions 1 and 2, which is what was demonstrated in that essential tremor video, so up by the chest and out in front of them. Then you can do action, so finger-nose testing, then test their gait, testing for rigidity and bradykinesia to make sure that there's none of that present, to make sure you're not dealing with a Parkinsonian tremor, and then check for any tremors in the head or the legs. Very good. Treatment of tremors, well, this generally tends to include drugs that aren't so great and tend to have lots of side effects, such as propranolol, primidone, topiramate. As you can see, lots of side effects, and if you can avoid them, and the patient says, don't worry, doctor, I can cope with it, then try and avoid them. But obviously, these are there if you want to use them. Obviously, if you suspect Parkinson's is the cause of the tremor, then levodopa is your best course of action. To move on to chorea. So when we talk about chorea, we essentially mean dance-like movements, irregular, purposeless, abrupt and rapid movements that are brief and unsustained. And they flow. There's a flow aspect to them from one part of the body to the other. And generally, when we're talking about chorea, we're talking about a very specific set of conditions. Probably the most common is Sydenham's chorea, then Huntington's, then other vasculitic processes like systemic lupus or antiphospholipid syndromes. Chorea can occur in pregnancy, called chorea gravidarum. There are other drugs that can cause it, and then lots and lots of very rare causes like DRPLA, neuroacanthocytosis, benign hereditary choreas, the SCAR syndromes 2, 3, and 17. And then neurodegenerative conditions with brain iron accumulation, the MBIAs or the neuroferritinopathies and ataxia-telangiectasia. So examination of chorea. So again, outstretched hands is generally the best, or really just when they're resting or walking. And it often comes out when you ask the patient to count or count backwards. This is one of the conditions I don't have a video for, but hopefully you can just go on YouTube or some other site and just have a look for yourselves. It's very, very obvious when you see it. To move on to myoclonus, this is a condition with sudden, brief, shock-like involuntary movements, which are usually positive, so upwards in their inflection, but can sometimes be negative. So this is when you have their hands outstretched and their hands flap. This is often seen, obviously, in CO2 retention, but also in liver disease. Myoclonus is probably best likened to the effect seen after you shock someone with an electric shock. It's very brief, very quick. And there are lots of causes of myoclonus. All of us have probably experienced myoclonus when you've been falling asleep. When you're falling asleep and you have a sudden jerk of an arm or a leg that just wakes you up from sleep, that's myoclonus. There are epileptic conditions that can cause it, as well as other conditions, rarer conditions such as CJD. But probably the most common neurodegenerative condition to cause it is Alzheimer's disease. So here's a video
this
now.
This patient exhibits generalized myoclonus as well as some myoclonus involving
very brief
lower more than upper
shock light.
extremities.
Count 1 to 10 for me, please. Can you count 1 to 10?
Okay.
Yeah.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
So you can see that you probably can't predict when the next of those is going to come, but it's very brief, very shock-like, affects everywhere. But this is a generalized myoclonus. You can get myoclonus that just affects, say, a limb or a segment, so just the lower limbs or just the upper limbs or just the head. And the last condition that I just want to touch upon are tics.
Thank you for making this video.
These are, again, unpredictable
How long
movements.
have you had the tics?
Since I was a young kid. But they got a lot worse since around 2002 or so.
And can you explain how it's been affecting your neck?
I have a lot of neck pain because of the continuous tics. It's constant pain, but especially when lying down and sleeping, it's a big issue. Yeah.
And when you're doing the neck tics, do you find you have to tense your neck until it feels painful?
Because sometimes not until it feels painful, but if I cannot do the tick well enough, sometimes I even have to pull my neck in some direction.
So the tick has to be right.
Yeah.
Thank you.
If I cannot do it strong enough on my own, I'll do like this. So yeah.
Thank you very much.
Very good. So you heard there that tics are a strange movement disorder. They are characterized by a urge. There is a internal drive to do that movement. They are suppressible. So if you were to ask that patient to not do that tic for 10 seconds, for the count of 10, they could probably do it. So they could suppress the movement for the count of 10. But then quite soon afterwards, they would develop so after the count of 10, they would rapidly do many of the tics to kind of compensate for not having done it for some time. So they're characterized by an urge. They are suppressible. They tend to be unpredictable movements, but quite patterned in, as you can see, it's always sort of neck orientated in this particular patient. They can be motor tics, so movements of arms or legs or neck, but they can also be vocal tics. So sometimes people have sort of throat clearing or humming noises. They can also be sort of orofacial, so sometimes blinking or sticking your tongue out and things like that. And they can also be corporalalia, so vocal tics in which people need to shout offensive words. So this is often associated with Tourette's or Touretteism, but other conditions can also cause it. So that is a quick whistle-stop tour through all things movement disorders. Hopefully you've learned that movement disorders can broadly be divided clinically into hypokinesia or hyperkinesia. When we talk about hypokinesia or bradykinesia, we mean Parkinsonism, and idiopathic Parkinson's disease is the most common cause of Parkinsonism, but there are other causes, the Parkinson's plus syndromes, that can also cause Parkinsonism. It's useful to be aware of those. When we talk about hyperkinetic movement disorders, we're really talking about a whole bunch of things: tremors, myoclonus, tics, chorea, and dystonia. When we talk about tremors, the most common cause of tremor really is probably benign essential tremor, but other causes also exist. Obviously, Parkinson's can cause tremor, but also enhanced physiological tremor, dystonic tremor. And when it comes to myoclonus, tics, and chorea, there are lots of rare disorders that cause these conditions, but it's useful to be aware of them, especially when it comes to trying to describe them and trying to characterise what the patient in front of you has. Obviously, I feel like that's been a very quick lecture, but if you wanted to go through it again or go back through it and pause at particular points, please feel free to, and hopefully that's been useful. Thanks very much.